Welcome to the first learning track session for the Housing and Services Partnership Accelerator. It's wonderful to be back together again, ready to dig in. It's been an intensive 6 weeks since the kickoff, and we want to say thank you for doing the needs assessment and the homework. We're still absorbing all the information, but please know our federal partners and TA providers are deeply committed to helping you reach your goals. Our first learning track is your top priority: aligning and coordinating housing assistance, matching and eligibility approval for Medicaid housing-related supports and services with consideration to disability, aging, and health organizations that support individuals. This first of 4 sessions is focused on the development of robust, sustainable partnerships at the state and local levels, because it's impossible to align systems without strong and deep partnerships. Next slide, please. To help us communicate with each other, please make sure you rename your Zoom square and change it to show your name and your state. To do this, click the 3 dots by your picture and select rename. Also, in the chat, please tell us, what do you hope to gain from this session? While you do that, we want to thank you for the homework, which we hope has generated some insights for you that are helpful. Many of you were willing to share your partnership assessment with other Housing and Partnership Accelerator states, and you can find these in the TA community's individual state discussion boards. Staff will drop a link in the chat for you to be able to access those. Next slide, please. While I give a quick overview of our time, please also mute your mic unless you're speaking. This session starts with some inspiration about the state of transforming systems for the people we all serve through housing, health, and social care networks. Then we are very fortunate to feature both Massachusetts and North Carolina state teams to share successful strategies for building cross-sector partnerships to pull together housing, health, and social care in an enduring way. Based on tax needs assessment findings, we're giving you the opportunity to dive deeper in 3 different breakout sessions for peer-to-peer exchanges. During that half hour, you can ask Massachusetts and North Carolina some questions. Then the TAC facilitator will shift your discussion to the questions in the agenda. Via the magic of Zoom, when we will all be back together, we'll hear recaps of the breakout groups and have a larger discussion before we close out. Next slide, please. Today, we have the honor of hearing first from one of our federal leaders, Kelly Cronin, who is our Deputy Administrator for Innovation and Partnership here at ACL. Kelly, the floor is yours.
Thank you, Ryan, and thank you to everyone who's making time for this session today. We're super excited to have all these state teams engaged in all of the work you're trying to do to address housing issues, housing insecurity, and doing that while trying to coordinate with services. Some really tough issues you're trying to tackle. We've been working on this at a federal level for the last many years, but really in a new, more coordinated way, I would say, across agencies in recent years. And I just wanted to start with just a really brief summary in the next slide of some of those things that we have been doing across agencies, so you can sort of get a sense on the federal side where we've been and how that might relate to you, and particularly how it connects across all levels of government, including to the community and county level. So I think obviously we all know that social determinants of health, health-related social needs beyond housing, including nutrition assistance and access to transportation, social connection, financial insecurity. These are all things that are often interrelated, and a lot of complex individuals with complex health and social needs have multiple health-related social needs that we need to address in a holistic way. So we've been across federal government working on how we best maximize all our programs and policies, and sort of put together a strategy, overarching strategy playbook, if you will, that I'll speak to in a little bit. But we also put together a call to action across HHS agencies, really emphasizing the need for everybody to come together for sustainable community partnerships. So if we're going to be able to address housing insecurity with services, and doing that in a person-centered way, it's going to take health systems and health plans and community-based organizations and continuity care organizations and public housing agencies, and everyone really working together to figure out how we leverage all our federal, state, county, local resources to meet individuals where they are and best support them. So I think you're already super familiar with all the flexibilities under Medicaid as you're implementing them, in addition to the waivers in lieu of services. But there's also a lot of changes that you're also probably familiar with, but on the Medicare side, there are increasing number of requirements related to health-related social needs screening, or drivers of health screening, as CMS has named them in rulemaking. And so hospitals now are routinely screening, or under the measures that they're reporting on, one of them is to routinely screen all individuals 18 years or older for housing insecurity, food insecurity, transportation access, financial insecurity. So it's anticipated that those that have housing instability are going to be more routinely discovered after admission before discharge. And then there's then the impetus to determine, okay, so what is your handoff going to be? How's that person going to be supported? Are they transitioning to a shelter, to a motel, to what other community access point? And how will they do that with services? So all that really gets sort of pushed into that encounter, that hospital stay. And we are trying to work across agencies to think, okay, if this referral volume is likely going to be going up because the health-related social needs will be better understood at all these different encounter points in healthcare, then how do we make sure at a community level those referrals can be acted on? There's the workforce, there's the data systems, there's the payment streams to be able to cover services over time. So a lot of this is baked into your waivers, but on Medicare, there are some increasing flexibilities to address not only doing the positive screen, but or doing the screen. If it results in a positive screen, you need to refer. Some of the coordination that happens after referral can be reimbursed now through the physician fee schedule in a community health integration code in partnership with community providers, Part B providers. So I just mentioned that we have been working a lot across agencies on how do we make all this come together, not just through screening, not just referral, but how does it work at a community level, and how do health plans, health systems, Medicaid managed care, dual special needs plans, nursing homes, how does everybody come together, and the CBOs that support all these people, the housing providers, how does everybody come together? We need connective tissue to be able to do this on a sustainable way where dollars get braided from all these different pots of funding, and the individuals can be supported throughout this continuum of care. So we've recognized that we need to be very diligent about what is that community infrastructure, how do we support it? And if you look, and you'll hearing more from North Carolina, but North Carolina did bake this into their 1115 waiver through the Healthy Opportunities Pilot, as has New York in their social care referral networks. As has Massachusetts through their certified partners with their early 1115 implementation, recognizing that these community entities that are really receiving the referrals, providing the services, making sure they can either provide housing navigation support or place-based service coordination, really all the follow through to make sure these individuals are supported and get what they need to be stable. All of that needs to be operationally operational infrastructure needs to be in place, but it needs to be supported, and often it requires some kind of upfront investment. So the next slide is just an emphasis that we, oh wait, I'm sorry, I'm going to pause because I think Molly wanted to do a Menti poll or a chat question first.
Yeah, folks just want to drop into the chat based on your homework with which organizations do you need to expand or enhance partnerships with the most in order to achieve your goals. And with that, we can go to the next slide. And
so yeah, just to mention again that one of the things we worked on across departments and agencies was an SDOH playbook with 3 main pillars or sort of areas of strategies. One around data and data sharing, which I know many of you are well into now and have some goals around that. The other is around, flexibility to be able to more easily braid and blend and get the right access to all the benefits, which is another topic I know you've all been raising and wanting to make it progress on. But the other third one, which I think some waivers are explicitly addressing, but maybe not all, is the support of having sort of that community infrastructure, community backbone organization. that we've been calling community care hubs, that can really be that sort of community-focused entity, often a CBO that is well established in the community, could be an area agency on aging or Center for Independent Living or another capable organization that has that presence in the community, has administrative infrastructure to build on. They can work with a network of CBO providers, similar to what was done under Healthy Opportunities Pilot, but they can be the entity that contracts with Medicaid managed care, that can work with all the health systems, work with the FQHCs, work with the public housing agencies, really be able to coordinate with the continuity care networks if it's about access to short-term rental assistance or vouchers. So really acting as that go-to entity. We think it's really important for that to be supported and to be not only supported as a startup phase, but also over time be able to move to sort of a multi-payer model where they will be the neutral entity, the trusted entity, but the administrative infrastructure that can pull all this together. So we are awarding funds in partnership with CDC to support this work. And I think some of the waiver implementation is also supporting these, maybe calling them slightly different terms, whether it's network leads or social care referral networks. But that's all a very similar concept. We worked with a lot of stakeholders outside of federal government that all came up with this term and concept together based on a lot of work that's been done successfully in many communities over the last 10 years.
Thank you
So
very
it's
much,
not
Kelly.
federally driven, but we are adopting the good successes of what's already happened. So that's just a little bit of context of what's been happening. And I know I don't have a lot of times, but the next slide is just a call to action we put out, just trying to get a lot of motivating a lot of partners to work together on this, as you all are already doing with housing and services. But we just wanted to explicitly call out that health systems are key partners in this, as are Medicaid managed care, D-SNPs, Medicare Advantage plans, and others that really do need to be thinking about how they not just build their own ways of doing this, but they are really partnering with community through hubs. Public health departments have been playing a really constructive role in many different counties. And health IT is a critical linchpin to this, but right now we have quite a bit of fragmentation that we need to solve for. So just we recognize this is a collective action model. It's going to take everybody, but it's also going to take a lot of coordination across all levels of government. So we encourage you to think about how you can bring community partners into this, as we are really trying to encourage all of us to work together on this.
Thank you, Kelly. And next slide, please. While cross-sector partnerships are essential to align our systems and resources so all may live stably and successfully in the community, we recognize that forming robust, sustained partnerships is not easy. And today, we get to hear from two accelerator states about their approaches, lessons learned, value generated, and the journey ahead. First, I'd like to welcome and thank our Massachusetts presenters, who are Gordon Calkins, Director of Individual Homelessness, Executive Office of Housing and Livable Communities, and Emily Cooper, Chief Housing Officer, Executive Office of Elder Affairs and Special Advisor on Housing of Mass Health. And Gordy and Emily will then turn it over to North Carolina presenters from the North Carolina Department of Health and Human Services, Maria Ramirez Perez, Healthy Opportunities Pilot Program Manager, Deborah Goda, Olmsted Transitions to Community Living Director, and Josh Walker, Olmsted Housing Director. Please hold your questions for the presenters until the breakout rooms. Each breakout will have Massachusetts and North Carolina team members, and the facilitator will moderate the Q&A before switching to the discussion topic. So with that, Gordy and Emmy, take it away. Emily, take it away.
No problem. Hi, everybody. I'm Emily Cooper, and I really appreciate you inviting us to talk today and to talk about Massachusetts. If you want to go to the next slide, we're going to really focus on sort of the key ingredients of a successful partnership, our areas for growth, and our lessons learned. I think the first thing is that it takes a village. So I want to just make sure to call out, we have some other folks on our team. We have Lena and Josh and Joyce, and you're going to hear from Gordy. So this is not ever a go it alone kind of thing. You know, as I think we just heard, it's a lot of work across a lot of agencies. I will also say, I was thinking about what is the real key ingredient of a successful partnership, part of it is longevity. Many of the people who are on our team, we've been working together in some shape or form, maybe from a different agency or from a different vantage point, or as a consultant, as a state worker. And we sort of all go around. There's not that big a universe of people in the health and housing world. So we all sort of been circling around each other and working with each other for many years. So we do have this familiarity that makes it easier to pick up a phone and call someone. So next slide, please. When we talked about what I think were new things and really helpful things for the partnership, we've started this kind of organic strategy of hiring people in other organizations with subject matter about something else. So I like to say, I work in the Medicaid organization, but I am a housing person. And I'm surrounded by Medicaid people. When they said they needed a housing person, they didn't need a Medicaid person who knows about housing. They know a housing person who may or may not know about Medicaid, because I can ask the 300 people who work around me. I have seen, unfortunately, many organizations, they say, oh, I'm going to do more in housing, but they hire somebody who knows more about what the agency does and not about housing. So what we've tried to do is we've actually tried to hire subject matter experts. Sorry, I just got muted. Hire subject matter experts and embed them in cross agencies. So an example of that is my position, where I'm a housing person, but I'm in the Medicaid agency. We also have Josh Cuddy on our team, who is the interagent. He comes from Human Services previously, and he's the interagency person, but he works at the state housing agency. The housing agency is also hiring people with expertise in justice involvement, because they're going to do justice involvement housing initiatives. And so it's really important that you're bringing that lens, because when I look at things at Mass Health from a housing or homeless perspective, I see things differently than the regular sort of Medicaid person. Sorry, Mass Health is the name of Medicaid in our state. So for example, when we did Medicaid redetermination, as with most of you, it's typically done via mail. That doesn't work for people experiencing homelessness. And so we were able to bring that up and figure out how else we could do things. So we actually worked with the housing agency, with Gordy, closely to organize on-site redetermination events and shelters. Housing, you'll hear from Gordy, but they've also struggled to figure out sort of statewide homelessness inflow and exits among households without children, individuals, because that makes it hard to figure out how much permanent supportive housing to build over time. And so they work closely with the Mass Housing Shelter Alliance and United Way to figure this out. So we look at the policies a little bit differently when you have a different background. I think I'm turning over the next slide to Gordy.
Thank you, Emily. And don't think I didn't notice that when you were talking about longevity, you made us all sound very old from Massachusetts. So, all right. So I'm going to talk a little bit about our stakeholders and who they are, and how built-in structural ways that we've created to make sure that we're getting good feedback from those stakeholders. So we think of our stakeholders as, first of all, our constituents, but also our state agency partners. So Department of Mental Health, Department of Public Health, Emily's shop, as well as the service providers from all of us touch homeless folks, and the continuum of care. We have 12 of them, which is far too many for the size of our state, and the municipalities. So we try to create some concrete repeating processes for making sure that we're hearing from all of those folks. So we've got a few examples up here. I'm not going to read them to you, but just to kind of point out, we've got built-in mechanisms, standing meetings with providers. We've got mechanisms for making sure that we are talking on the ground with homeless constituents in shelters and permanent supportive housing and transitional housing programs and street outreach programs. That is an area we're still working on trying to get even better at, but we've got a process in place. And so the importance of this is, of course, is to understand what problems are, and then to be able to come back together as a group and to solve those problems. So the example here that we've got on the slide, I think is your idea of an example, Emily, and it's probably the best one I could think of as well. A number of years ago, we were hearing about a lot of the shelters were saying, we keep getting these folks who aren't really appropriate for shelter, and the hospitals they're just showing up from the hospitals. We know that that's not unique to Massachusetts. It's kind of a common problem. And so we worked to develop a process and a set of trainings for hospitals, so they had a better understanding of how to divert people in ways that didn't send folks who couldn't manage in a shelter. We, to kind of close that communication loop, we also worked with shelters. All of this is ongoing work, but we also worked with shelters so they understood the pain points of hospitals, and that hospitals don't have any control over where a person goes once they've been discharged, or they can't even really engage in discharge planning for somebody who showed up at the emergency room and wasn't admitted, and they get their care and they leave, or they leave even without care. So there's been a lot of that kind of communication. Emily and I can't remember what Mary Louise's title is, from Health and Human Services, do kind of perpetual retraining of hospital discharge staff, simply because discharge planners in hospitals, that's a position that turns over a lot. And so it's an ongoing, iterative, probably never-ending process, but we have found it's actually been reasonably effective. We have far fewer complaints about people showing up at shelters that didn't know that they were coming. We have far fewer complaints about people coming to shelters that aren't really appropriate. And when we do, we now have a mechanism for making sure that that doesn't get repeated, and that things are moving along, and that the relationships between the healthcare provider and the shelter can be preserved. I think I'm supposed to say we should launch the poll. So next slide, and then launch the poll. All right. Oh, go ahead.
Oh yeah, I think our poll, we're having some technical difficulty. So if folks could just drop your response into the chat. So from which groups do you solicit and incorporate feedback on state policy decisions to align and coordinate services? People in our priority populations, local providers or housing and or services, other state agencies, state level nonprofits or associations, subject matter experts, or other or not applicable. And we can go to the next slide, and Gordy, you can continue.
Alrighty. I was expecting a break for a drink there. All right. So this is kind of this is our areas of growth, what we're hoping to get from this process. We're hoping to understand some things better. And so I'll offer just a little bit of background. So we're focusing on ultimately, we have nowhere near enough permanent supportive housing. We have a number of mechanisms already in the works for expanding that, including a housing bond bill that we're hoping we can bring to its conclusion by the end of this fiscal year. Conclusion, that's not right. We could commence, I think, actually, is probably what we really want to say. And then I'm sorry. And so we're focusing, in order to expand permanent supportive housing, we're trying to focus on a number of things. So part of it is, yes, we need financial resources for rental assistance or acquisition and that sort of thing. But we also need to better understand how, what our various current funding streams are for services for folks who are experiencing housing and moving out of, experiencing homelessness and moving into permanent supportive housing, and try to understand what gaps we might have, where there are folks out there, we know there are, who aren't eligible for any of the services that are currently available. Are there better ways to leverage our Medicaid funding for that? And then in our bond bill, we have the opportunity to build a supportive services pool that is specifically for this. And so understanding this now, before we get to building that, will allow us to build that to fill any remaining gaps. Second thing we're really trying to understand, trying to get is, so we have 12 continuums of care. Massachusetts is, I can drive from one corner of Massachusetts to the other in about two and a half hours. So it is not a big state. And that's a lot of continuums, a lot of different systems, and continuums tend to be, it can be kind of right on top of each other with systems that are not necessarily aligned in the way they assess vulnerability and how they prioritize their folks for permanent supportive housing funded through funded through continuum of care. And so we're hoping to use this to, first of all, understand what the variances are for those coordinated energy systems, and then to determine methods for us to be able to integrate eligibility for other kinds of services while they're working through coordinated entry. And then finally, I think our third bullet is really what I think, I imagine all of us are hoping for, which is to understand how others are addressing a variety of things. In particular, we're concerned about there's some disagreement amongst ourselves around some fair housing concerns. Can you create a housing project that is specifically for a very specific population with perhaps that has a specific type of health insurance or a specific health insurance provider? And so we're hoping that others may have cracked this nut and can provide us with some counsel about whether or not we're all wrapped up over nothing, or if there is a problem and how you work through that. Next slide.
So I think this is me, Gordy.
Yep.
Thank you. So they asked us to talk about lessons learned, and I think I'm going to wrap up because I think my time is up. This takes a long time, and it can't just be added on to other people's workload. It really needs to have dedicated staff working on this specific thing. And I've seen a lot of people say, oh, I'm a population health person. I do this, and this. And it really needs, that's at least what we've discovered. I also, as the person who's working on the 1115 waiver at the Medicaid agency, don't underestimate how much that's going to take. For those of you who are new to it, even just the negotiation, we have weekly calls with CMS to parse words, and that's not even operationalizing. So the time it takes to get these programs approved, operationalized, and working smoothly is years, not months. And that's with teams of people. So don't underestimate that. And then the last thing I will say is that it's, the relationships are there, but they kind of still need to be nurtured over time. You've got new governors and new people in charge and government changes, and you want to make sure that you may need to make new friends. The friends may move into different positions, but you need to continually, it's like a plant. You need to continually nurture it and give it water and allow it to grow. And it's hard work. So celebrate the small wins and the big wins. So that would be kind of my lessons learned and advice. I think I'm supposed to stop the poll, but we didn't have the poll. So maybe
I think we can just hand it right over to our friends.
I'm going to hand it right over to the North Carolina team.
Thanks, Emily.
Okay.
Thanks so much, Emily. And I for one personally could just say everything Emily said and just walk away because it made me think about a lot that we've gone through and that we're going through as we move along our journey in this space. Next slide, please. I did want to mention we do also have a larger team that spans agencies within our DHHS and our North Carolina Housing Finance Agency partners. and our local management care entity, managed care organization partners, community partners. So this is much bigger than the 3 people that you see presenting today. So a couple of things that we want to talk about today are things that impact how we are providing services and working with people who need housing. And that would be the managed care authorities that we use, the services that we are able to provide that support permanent supported housing, and our Healthy Opportunities pilot through Medicaid. So I have, 3 minutes to cover the entirety of our program, so I'll start now. So in 2015, we were legislatively mandated to move to an 1115 authority. We were managed care in the behavioral health space, starting with a pilot in 2005. So we did do it a little bit backwards. So now we have an 1115 in place. We have standard plans that take care of individuals who have low to moderate behavioral health needs. And then we have tailored plans, which will be launching July 1st, which are for the more severe, moderate to severe population for mental health, substance use services, be the intellectual developmental disabilities and traumatic brain injury. So we have collaborated with many, many people and organizations in our state, clinicians, hospitals, our advocates, our stakeholder advisory groups, to build a program based on whole person care, not separating the body from the head, being able to buy health and paying for health and not just for fee for service. You do one thing, you get paid one rate. Care management at the local level, so that there is provider-based care management near where the person is, who can come see them in their home or in their community and get them connected to what they need. A good member experience and making sure that services are user-friendly, timely. We close loops so we know what's been proposed has been completed, and provider access. So trying to remove as much provider abrasion as we can so that they can focus their time on the individuals that they're supporting. Next slide, please. So this is just a brief overview of what's changing between our current LME MCO model, which is under a 1915 BCC combination, to the tailored plan, which will be under the 1115 authority. So we're going from just the behavioral health IDD, TBI, SUS services to integrated whole person care. So our agencies, our MCOs can now provide the full array of services to individuals and use those levers to get the physical health services that our folks need. It's going to cover individuals who have Medicaid, and individuals who require who need state funded services, though they will not be eligible for that Medicaid benefit. We are still going to be, and this is an old slide, so I apologize. We no longer have, health choice has been wrapped into Medicaid in our state, and the other populations will be receiving services through the tailored plan. We're moving from a care coordination administrative case management function by the LME MCO to a very robust tailored care management done by the LME MCOs and by private organizations who will be connecting that individual and managing their care. The contracts, we're going to have one contract that we share with our Division of Mental Health, Substance Use, Developmental Disabilities, Substance Use Services Agency, and Medicaid, so that it is more streamlined than having one agency having to deal with 2 different contracts. Oversight is no longer just the behavioral health unit managing this contract. but it's matrixed across the entire organization, everything from eligibility to program integrity. Closed networks, we're going to maintain for now our closed provider networks so we can build up our behavioral health organizations, but we will have open array for our physical health. And our LME MCOs are local quasi-governmental agencies, and we don't know what that's going to look like in the future. Next slide, please. And I have to talk faster because I'm running over. So we have some services that cannot be offered with our standard plans. They're the enhanced behavioral health services on the right-hand side of the page. And some of these, such as ACT, Community Support Team, and peer supports on the left side of the page, these are services that we use for tenancy supports in North Carolina, along with a state-funded service called TMS, Transitional Management Services. Now I've gotten all confused. But we use, I'm correct, yay. We use all of those to support individuals who are moving into housing. And next slide, because I am over and I apologize to my team. So the oversight of Medicaid managed care is across the organization. Our goal is to proactively identify issues and get that remediation started right away. Continuous quality improvement, working with our partners to make sure that everyone has a part and a voice and eyes on, and we link with CMS, the state, other entities to coordinate oversight of our plans. And next slide. I will turn it over to Josh, who's going to tell you about Centers for Independent Living. And I'm sorry, Josh, you only have about a minute, so talk fast.
Mute. All right, not a problem. Thank you, everybody, for your guys' participation today. My name is Josh Walker. I'm the Olmsted Housing Director. I previously came from one of those LME MCOs that Ms. Deb was just referencing earlier. And as such, I was on the ground with the Center for Independent Living and the initiative that we had for collaboration with them in 2019. ADA&C and East Point was the pilot. And quite frankly, I was there at the beginning and looked through that for about 5 to 6 years. So I got to see firsthand all the wonderful partnerships we were able to develop with that ADA&C and with that SIL. We also had partnership with Temple University and Dr. Salzer as far as being able to have data to show what we're doing and making sure that it's effective. And because we were able to show that it was effective, in the East Point catchment area, 3 out of 4 individuals who were receiving the add-on piece of community integration, community inclusion with ADA&C, 3 out of 4 did not separate. So we were able to show that this was extremely effective. And the other part that I can say that had a very big impact there, the collaboration with this partnership has also allowed us to expand across our individual placements and supports, which is our IPS service to assist individuals with working. Ironically enough, if I go and tell the people, hey, you should get a job, they look at me and smile and laugh. However, if we have an individual who's a peer who's been there, done that, got the recovery badge, and can work with them on an individual level that, quite frankly, sometimes clinicians such as myself cannot, they have a lot more success. And that's something we've definitely seen, and it's spread all across the state. And every one of our LME MCOs does now have a partnership, either with a SIL or with a peer run organization. And we're looking to figure out all the different ways we can expand that throughout our transition to community living initiative, as well as other areas for housing across the state. And speaking of other areas of housing, I'm going to pass it to Maria, who's going to talk with us next about healthy opportunities. So next slide, and Maria, you're up.
All right, this is going to be quick. This is a couple of slides in, so I'll just hit the highlights. So overall, North Carolina, within our 1115 waiver, requested authority to be able to provide an array of services in housing, food, transportation, and personal violence. For housing in particular, we were working to be able to address whole person care to promote equity. And this meant focus for North Carolina, this meant addressing not just imminent homelessness, but looking at housing insecurity more broadly. So looking at services that may help address things like healthy home goods or repairs for a home to keep somebody housed. Next, or never mind. For the kind of the overarching infrastructure, the state is currently operationalizing this pilot in 33 primarily rural counties. These regions were identified by network lead entities, which are the care hubs that North Carolina has in place to support a network of community-based organizations. Those hub organizations are, two of them are care management organizations, so they are a part of a health system and are part of the overall managed care care management structure. And another is a grant-making foundation. I would say as a lesson learned for other states that are interested in doing this type of work or bringing on care hubs, there's been a lot of success with both types of entities. For those that had care management and Medicaid experience, there's certainly a bit of a leg up in being able to operationalize policies. However, for those that, for the grant-making foundation, they had just a large network of community-based organizations that they knew, that they had vetted, and that they were able to begin supporting rather quickly. So things to keep in mind in terms of that onboarding piece. Now this pilot does involve an evaluation. So as part of this work, there has been a rapid cycle assessment that did look at the overall efficacy of having these network lead or hub entities. And we saw a lot of early findings really showing how they help support the development of this accountable infrastructure and the promotion of sustainability for community-based organizations. Onto the slide that's on the screen. The populations that are eligible for these services in North Carolina are Medicaid enrollees that live in one of the HOP regions. Now, this is under our current waiver. We are requesting authority to expand services statewide. But currently in those 33 counties, members would have to reside there, have at least one behavioral or clinical health criteria, and meet at least one social risk factor. Now, next slide. And then for North Carolina, there are many different stakeholders, and I will say I echo so much of what Massachusetts was saying. So just to, the pieces that I would add is there are, don't underestimate the importance of just having those frequent and points of contact with these different entities and to bring them together to talk to each other and to problem solve. I think some of the earliest lessons that we really had with implementation of this pilot is the department set up many different meetings with each of these entities individually or bringing together by entity type. And we saw the most success when we started to bring everyone together so that they could see the full picture of what this program looks like and how different elements impacted that different policies that we may roll out for a network lead may impact a health plan. The department at times may not see that immediately, but these entities were able to talk to each other, and we were able to help facilitate some of those updates and guidance or in policy much more quickly. So I think I will say that has to be very intentional from the part of the department. So just something to bear in mind that we've had to certainly learn and internalize as we move forward. The other piece I will add is to always keep in mind simplicity. It is something that we tell ourselves daily with operationalizing the Healthy Opportunities pilots. And I think a part of that is trying to simplify policies for stakeholders and also trying to keep the decisions, ensure the decisions that are made do not overly complicate the processes that will be put in place. One example of this is North Carolina made the decision early on to have invoicing rather than claims-based reimbursement for community-based organizations. That is one way that we could bring in a more diverse array of community-based organizations into this pilot. Currently, providers may include things like legal services organizations or some faith-based organizations, shelters, local health departments, and many other types of entities that can provide, again, that wide array of services that can both help prevent eviction and support housing for a member to remain housed, and can help support that identification of new housing, or help get somebody newly housed. So with that, Ryan, I will turn things back to you.
Great. Thank you so much.